VQ mismatch and shunting. Understanding respiratory physiology. Understanding ventilation-perfusion matching is essential for any clinician managing hypoxic patients. It is the key to diagnosing the cause of hypoxemia, interpreting the AA gradient, and understanding why certain conditions respond to supplemental oxygen while others do not. We go deep on VQ physiology, normal matching, mismatch, shunt, dead space, and the clinical conditions that cause each. In a perfect lung, every alveolus would receive exactly the right amount of ventilation and the right amount of blood flow to maximize gas exchange. Ventilation, V, delivers fresh oxygen and removes carbon dioxide. Perfusion, Q, carries deoxygenated blood to the alveoli and oxygenated blood away. The ideal VQ ratio is 1, equal ventilation and perfusion. In reality, even healthy lungs have regional VQ variation due to gravity. In an upright person, gravity pulls blood preferentially to the lung bases. Perfusion is greatest at the bases. Ventilation also increases toward the bases but less steeply than perfusion, so the bases have a lower VQ ratio, approaching 0.6. The apices receive more ventilation relative to perfusion. VQ ratio at the apex approaches 3. This is why tuberculosis, which thrives in high oxygen tension, preferentially affects the upper lobes. The normal VQ ratio is 0.8 overall. Any deviation from this, either too low, mismatch, or too high, dead space, impairs gas exchange and causes hypoxemia. VQ mismatch occurs when perfusion is preserved but ventilation is reduced, or when ventilation is preserved but perfusion is reduced. The most clinically relevant form is low VQ, perfused but poorly ventilated alveoli. Examples include pneumonia, atelectasis, pulmonary edema, and asthma. Blood passes through these poorly ventilated areas without being fully oxygenated, which is called venous admixture. The result is hypoxemia. Critically, low VQ mismatch responds to supplemental oxygen, because increasing the FiO2 can still reach these partially ventilated alveoli and improve oxygenation. Dead space, high VQ, occurs when alveoli are ventilated but not perfused. Classic cause is pulmonary embolism. Blood flow is blocked, so ventilation of those alveoli is wasted. Dead space does not contribute to gas exchange. Physiologic dead space includes anatomic dead space, airways and conducting zones, plus alveolar dead space from unperfused alveoli. Increased dead space causes hypercapnia if the patient cannot increase minute ventilation to compensate.
True shunt is the extreme of low VQ, areas where there is zero ventilation but perfusion continues. Blood passes through completely unventilated alveoli and returns deoxygenated to the left heart. Classic causes of shunt include severe pneumonia with complete consolidation, ARDS, pulmonary AVM, and intracardiac shunts like VSD or PFO with right-to-left flow. The defining feature of shunt, it does not respond to supplemental oxygen. No matter how much oxygen you give, blood passing through unventilated alveoli cannot pick up that oxygen. The only way to improve oxygenation in shunt is to recruit alveoli, with PEEP in mechanically ventilated patients, diuresis in pulmonary edema, or antibiotics in pneumonia. This oxygen response test is clinically invaluable. If hypoxemia corrects with supplemental oxygen, think VQ mismatch. If it does not correct, think shunt or very severe mismatch approaching shunt. The alveolar arterial gradient, AA gradient, quantifies impaired gas exchange. The alveolar oxygen tension is calculated from the alveolar gas equation. PaO2 equals FiO2 times atmospheric pressure minus water vapor pressure minus PaCO2 divided by the respiratory quotient. On room air, PaO2 equals 0.21 times 713 minus PaCO2 divided by 0.8. The normal AA gradient is less than 10 to 15 millimeters mercury in young adults, increasing with age, roughly age divided by 4 plus 4. An elevated AA gradient with hypoxemia points to a pulmonary cause, VQ mismatch, shunt, or diffusion impairment. A normal AA gradient with hypoxemia points to hypoventilation as the cause, low inspired oxygen at altitude, or neuromuscular respiratory failure. Diffusion impairment is the fourth cause of hypoxemia. Thickening of the alveolar capillary membrane reduces oxygen diffusion, seen in interstitial lung diseases, pulmonary fibrosis, emphysema. It worsens with exercise when transit time through capillaries shortens. It responds to supplemental oxygen because the gradient is maintained. Oxygen still reaches the alveolus. Clinically, integrating VQ physiology helps you rapidly categorize hypoxemia. Is the AA gradient elevated? Does oxygen correct it? Is there evidence of dead space on capnography? These three questions narrow your differential in any hypoxic patient. Subscribe to Medical Sciences Unfolded for daily deep dives into physiology, pharmacology, and clinical medicine.